经理主任，经理主任，听得到我声音吗？
可以可以。
哦，谢谢谢谢谢谢。晚安，大家晚安，大家晚安。
晚安晚安。赵主任，待会放完你的那个 video 之后，你要不要跟大家讲几句话？
哦，
是要直接进 panel？
我觉得是不是直接进 panel discussion 也可以？我想一下哈，
看你，因为我是想说，如果 OK 的话，就 Q 你一下，让你跟大家讲几句话啊。如果说你觉得
也可以啊，
直接进
也可以，
panel 也没关系，
可以啊。
这样子哈，
那你
那我就
就
Q
Q
你一
我好了。
下哦。
对 ，OK， 好，谢谢
好
谢谢。
，OK， 没问题，谢谢。
Ladies and gentlemen, welcome to THQA-JCT and the ASQUA Medical Quality Library International Master Webinar Series. And President Wang and President Jen and Professor Abdul and Dr. Zhao and Dr. Lin and Dr. Li and Dr. Wu and Dr. Chen. It is nice to meet you at the internet at the webinar. My name is Wei Chun Huang. I'm chairman of the THQA International Cooperation Committee. Today, our topic is main focus on accreditation and quality. So we invite two distinguished speakers from Malaysia, CEO of Malaysia Quality Society, and also expert to join this session. And this session is organized by Taiwan Healthcare Quality Association and the Joint Commission of Taiwan and the Asian Society for Quality in Healthcare. So let's invite the president of the THQA, Professor Zheng, for opening remark. Professor Zheng, please. So maybe we invite the Professor Wang first. Professor Wang is the president of ASQUA at this moment and also CEO of JCT. Professor Wang, please.
Good evening, everybody. Welcome to this International Library on Medical Quality webinar again. 20 days ago, we had a session 1 webinar about accreditation and the quality that received very positive and exciting responses from our audiences. So today, we will continue to the part 2 of this event to discuss more about the effect of accreditations on healthcare quality. So I would hope the success of today's event, and I hope all of you can enjoy the event of tonight. Thank you.
Thanks, President Wang. And next one, we invite our president of the Taiwan Healthcare Quality Association and also president hospital affiliation to Fuyin University of Sciences and Technology. Professor Zheng, please.
Good evening. Welcome to the International Medical Quality Forums held in Taiwan. Today's topic still focus on accreditations and quality. This is part 2. I'm Dr. Zheng Shaoyu, the chairman of Taiwan Healthcare Quality Association and the superintendent of Fuyin University Hospital. Today, I'm very pleased to open at the forums on the accreditation and quality in healthcare with the Joint Commissions of Taiwan in Healthcare, JCI Taiwan, and the Asian Society for Quality in the Healthcare, ASQUA. So most of people and staff in the healthcare believe that the accreditations and the quality is very difficult to balance and not easy to achieve the preference in the healthcare organizations. However, if we have the right circumstances and the scale, the cognition or concepts, the goal of the accreditations and the quality is easy achievements. Tonight, there are two outstanding quality experts. One is the professors, the two, Abdul Rahim from the Malaysia, and the second speaker from the Taiwan Ting-Hsing University affiliate hospitals, Professor Dr. Ting-Hsing, medical expert, to share their experience and visions. I look forward to every healthcare provider online have vivid discussions with the responses and enjoy tonight. Thank you.
Thank you, Professor President Zheng. Next. If you have any question Q&A, please use a Slido to leave a message at the Slido. Thank you. Next one. This event is organized by different society, and we have a serial master series. Please keep follow up our website. Next one. So first, we will invite the director of the Quality Care Center in Yuan General Hospital, Dr. Wei Chen Lin, for moderator the first speech. Dr. Lin, please.
Thank you for Professor Huang's introduction, and also thanks Taiwan Healthcare Quality Association, JCT, and ASQUA to inviting me to this meeting. I'm Wei Chen Lin. I'm a director of cardiovascular department in Yuan General Hospital, and it's my honor to join this online meeting with many experts here to share the experience of accreditation and quality. Today, the first section, we will discuss about the hospital accreditation and quality in Malaysia. The honor is mine to introduce our first speaker, Professor Dato Dr. Abdul Rahim. The professor is a CEO of Malaysian Society of Quality in Health, and he is famous in health service, hospital management, certified medical impaired assessor, and hospital accreditation surveyor. The topic today is hospital accreditation and quality in Malaysia, a journey and experience. Let's welcome Professor Dato Dr. Abdul Rahim. Professor, please.
Greetings, everyone. I'd like to say thank you and my appreciation to ASQUA and JCT and the Taiwan Healthcare Quality Association, and in particular, Professor David Huang, for inviting me to speak today in today's webinar. My topic today is regards to accreditation and quality, supporting complementary relationship. It's about the journey and experience that we, particularly myself, have gone through with regard to the development of quality and the accreditation program in Malaysian healthcare system. Okay. MSQH is a non-governmental organization, not for profit. So I'd like just to introduce where I work, and MSQH is for short from the Malaysian Society for Quality in Health, and it is the national accreditation body for healthcare facilities and services recognized by the Ministry of Health Malaysia and Standards Malaysia. Standards Malaysia also recognized MSQH as a standards writing organization for standards in healthcare facilities and services. It's also a member of the International Society for Quality in Healthcare, ISQUA, and a member of the Asian Society for Quality in Healthcare, ASQUA. In 1995, there were plans to establish MSQH as a vehicle or medium for the National Accreditation Program. However, in order to get the buy-in from the private hospitals, the accreditation program should not be an initiative driven from the top down by the Ministry of Health. The philosophy about quality is that it should be taken up voluntarily, because if the government gets over-involved, then people will just do it for the sake of having to do it. And you may not have the inspiration and the will to excel. And if you do not have the will to excel, then the organization is likely to stagnate or get worse. And so we have the involvement of the APHM, the Association of Private Hospitals Malaysia, the MMA, the Malaysian Medical Association, and the AAM later on, the Academy of Medicine of Malaysia, and as well as the Malaysian Nursing Association, the NMNA. I would like just to start with regard to our healthcare system and healthcare structures in particular. Basically, the structures are delivery structure, the financial structure, and the intermediary structure. For a long time, there was no measurement or system that gave people such information about the healthcare that was provided and delivered. And in 1995, as part of this program, the ministry started putting into place the building blocks for the quality assurance program and the risk management system. And as you can see, quality management system as an internal program is at the operational level perspective. It's about controlling the variations like healthcare, the quality for the goal of quality and safety. It's also emphasized documentations and keeping of records. And it is driven by strategies as a measurement system and accountability and the face-to-face and belief system. And basically, when we talk about quality management system, is driven by market forces in the sense that the patient, the public, the patients, the consumers, expectation, their satisfaction, drive the what you call the quality management program. Right. So the building blocks some of the building blocks that was developed and established was of course the national indicator approach and the hospital-specific approach in the quality assurance program, as well as the incident reporting and root cause analysis for the risk management system. We also established the audit, medical audit, such as the mortality and morbidity review, the corporate culture, continuing professional development, the national specialist register involving the specialty and subspecialty certification. And also we developed the credentialing and privileging program. At the same time, since 1997, the Ministry of Health hospital support service was managed by concessionaires by contract to look after the facility and engineering, biomedical system, the environmental services, as well as the housekeeping, clinical waste management, and linen and laundry services. As you know, there are challenges in the external environment, geographically, climate change, political, legal, economic, financial, social, cultural, technology, ICT, and also in the industry and the market environment. Some of the challenges is about the business of medicine, the business of healthcare, where the private sector is involved. Yeah. The values, they are quite different from the public sector. Particularly we got to business for profits versus the clinical governance. We also have issue or challenges in public-private consumer trust and confidence. They are definitely waning, particularly with regard to the public-private dichotomy, differences that are quite glaring with regard to accessibility, affordability, and the effectiveness. The issue or question with regard to public healthcare services quality and overcharging in the private sector. And we also face the challenges of technology, where in some aspects, the technology determines of what we do. Whether we should approach it as technology driven rather than determinism. But for some time, hospitals in Malaysia still did not have any means of measuring and assessing whether or not their processes, procedures, and facilities were in line with quality standards and best practices. So the problem was an issue of how do we know what we are doing are the right things, and then how do we show that we are doing the right thing? The answer is standards. In 1991, the idea of accreditation was raised. 1991, where quality requires an external program, a system-level program, driven by peers, fellow professionals, to control the variations in healthcare in terms of that everybody is actually doing the right thing, right? And accreditation, our accreditation goal is particularly in trying to integrate public and private sector commitment for the same standards of care for all. And in accreditation, we are working, sort of complementing the regulatory forces, particularly legislation that was established in 1998, right? The Private Healthcare Facilities and Services Act. At the same time, the Ministry of Health was taking the lead in introducing quality standards and measurement to public hospitals in Malaysia. The same was not the case for private health sector. Back then, there was no system in place for private hospitals in Malaysia to demonstrate that their processes were proper, that they were providing quality service and successfully managing cases. And so the then Director General, Tan Sri Dr. Abu Bakar, decided that it was time for a national healthcare accreditation program that will cover both public and private healthcare institutions in Malaysia with respect to the same standards of care for all. Some of the regulatory process, as I mentioned earlier, early on, in complement with the legislation, is the professional guideline and standards that was developed in 1997 after MSQH was formed then, and focusing on clinical governance. And for MOH hospitals, while they were not bound by the private sector legislation, there were administrative orders or rules, and even financial rules, where the Ministry of Health or the government, Ministry of Finance, advocate that all public hospitals to undergo accreditation, and henceforth, since 2009, we had MSQH have had contract with the Ministry of Health to actually evaluate, educate, and enable the Ministry of Health hospitals towards accreditation. Right. So since 1997, the Malaysian Society for Quality in Health has been the body responsible for advocating, promoting and supporting continuous quality improvement and safety in Malaysian healthcare arena. One of the things we tried to impress on the surveyors that they were educators and not inspectors, because standards and quality is not about passing or failing, but about developing a culture among the staff in the organization so that they will keep on looking to improve, to continuously improve and do better. The biggest accomplishment of MSQH up to date is the fact that the hospitals, both public and private, are now applying regularly to be accredited. However, there is caution, right? In our zealousness for consistency, minimizing variation, what works for me doesn't necessarily work for you. One size doesn't fit all. MSQH has arrived to and achieve the goals so far, and from the start, Malaysia was not led, but only guided by any other country in this process, and that the Malaysian system did not try and reflect other countries' standards or development. Right. And as Len Payne, the MSQH WHO consultant, during his latest visit 5 years ago to Malaysia, stated that he was proud the system has always been developed by Malaysians for Malaysia. So corporate culture, the caring, professionalism and teamwork is very important to be considered during our development of accreditation program as well. How work is designed and the resources committed to it, the commitment, the openness, and the empowerment that has to be there to ensure that the accreditation program keeps continuously improve to meet the ever changing standards or upgraded standards through the years, particularly regard to the guideline by ASQUA, IEEA standards. There's diversity, right? Whether it's regional, whether the size of the facility and the services that they provide, the leadership, how things are organized and managed, and of course, how human resource are organized and developed in the healthcare system. These are very important considerations when we want to strategize the education program in our country. Recently, there is a shift in focus since the year 2020, when COVID pandemic sets in, started. We are looking after 25 years of doing the same. We are looking at a shift in focus from what we do now in terms of looking at the structures, process, and outcomes as in the Donamidian framework, quality assurance framework. We got to the care setting and resources, and establishing culture, quality, and continuous improvement. We are shifting towards more engagement and empowering people, in particular the providers and the consumers. We are looking more from quality improvement activities and more efforts on risk reduction activities. Continuous improvement towards people, patient-centered care. The goals is the same: better care and safer care. Okay. So, with that aspect, on that point, we're looking at in our next edition of the standards to focus on people and patient-centered care, to focus on continuous and seamless care, the goals of tailoring to individuals or groups, right? Through getting people to be more informed and empower them, and try to get care closer to or at home, in particular in the digital healthcare environment. And to do this, we will be focusing on patient trails and process trails, and encouraging multidisciplinary team processes. One of the other things that we are also looking at the same time is centers of excellence, from quality-2 accreditation to professional and consumer empowerment, and now towards formalizing centers of excellence through empowering people, through resource commitment, public accountability, where there's openness and transparency, the need for the healthcare facilities to demonstrate performance, care that's the institution, the centers that and care that's centered on knowledge, and emphasizing on proven technologies, and not necessarily cutting-edge technologies. Moving forward, the biggest challenge that MHKH faces now is sustainability. This means ensuring that it has proper succession planning and that the standards evolve along with healthcare. It will take a lot of resources to make the changes because you have to plan for it. We need to have sustainable program to train the surveyors and the institutions undergoing or planning to undergo accreditation. We also need to have a stronger foundation to face the crisis, as we did for the recent COVID pandemic, to ensure that we are more resilient to face other challenges or crises in the future. One of the things that we are looking into developing and establishing is an integrated healthcare structure that would emphasize the quality and the risk management system and the accreditation program that is embedded within that system, all right, and is part of the structures. As you can see, my personal point of view is that quality program and the risk management program is compatible, and accreditation program with the accreditation program, and they complement each other. The important thing is to regard the accreditation program as an intermediary structure that facilitate and support the provision and delivery of people-centered care, and the need for the financial structure to also be what we call integrated to support the provision and delivery, as well as the intermediary structure. What's important is the quality culture plus commitment, openness, empowerment are important values that we need to have developed and established in the healthcare system, in our healthcare system, to ensure that the quality and risk management and the accreditation program would be sustainable in the future. Thank you.
Thanks for Dr. Rahim, a very excellent presentation to share the experience in Malaysia. I think many audience may have some question about the accreditation and quality, but I think it's over 8 o'clock and we may go through to the next session. The next session, we will discuss about the impact of disease-specific care certification on healthcare performance and clinical outcome. And the moderator of the next session is Dr. Jun-Yi Lee. He is a director of medical quality department in Magai Memorial Hospital. Let's welcome Dr. Lee. Dr. Lee, please.
Dr. Lin, good evening, every guest. I'm Jun Lee from Magai Memorial Hospital. I'm a cardiovascular surgeon and in charge of medical quality management in my hospital. It is my honor to introduce my good friend and colleague in Cardiology Society, Professor Ting-Hsing Chao. Professor Chao was graduated from Taipei Medical College, and he is now the chief of cardiovascular department in National Cheng Kung University Hospital. He has excellent performance in clinical practice as well as basic research. He is also active in participating in quality improvement activity, both in his hospital and also in the Joint Commission of Taiwan. He is an important committee member of the Disease-Specific Care Certification. Professor Chao is going to give us a talk today, and the topic is Impact of Disease-Specific Care Certification on Healthcare Performance and Clinical Outcome. Let's welcome Professor Chao.
Thank you, Chairman. Ladies and gentlemen, it's my great honor to be here to give a talk on this fantastic symposium. I'm Dr. Chao from National Cheng Kung University Hospital, Thailand, Taiwan. First of all, I would like to thank to the organizer of this meeting for inviting me. This is my curriculum vitae. I will be appreciative for your further comment. What is Disease-Specific Care Certification, so-called DSC? The DSC was first implemented by the Joint Commission on Accreditation of Healthcare Organizations in 2002. The core element of these programs are compliance with the consensus-based national standards, clinical practical guidelines, and organized approach to performance measurement and improvement activity. In 2009, the Joint Commission of Taiwan developed DSC program. The initial disease entities included coronary artery disease, acute coronary syndrome, and acute myocardial infarction. Nowadays, we have 15 diseases in total. What about the impact of DSC on healthcare performance and clinical outcomes? I believe that many people are curious about it. For example, the patients, healthcare provider, the policymakers, and the stakeholders, etc. There's a long belief that the accreditation or certification can improve healthcare quality. But how? In my opinion, the extrinsic pressure from the certification or accreditation can drive further intrinsic improvement in healthcare quality by remodeling local culture and establishing infrastructure. This intrinsic quality improvement can in turn to make a success in the certification or accreditation. What about the impact of the DSC on outcomes by quality improvement? You can check not only soft endpoints such as the quality indicators, customer certifications, but also the hard endpoints such as the prognosis of the disease, length of stay, readmission, and the cost effectiveness. Where is the evidence? I would like to share with you our experience and some evidence in the literature. You know that the cardiac-directed medical therapy is very important for patients with heart failure or acute coronary syndrome. However, when we look at the real-world evidence, there's still a room for improvement in the real-world practice. In order to promote GDMT prescription and the rehabilitation smoking abstinence consultation, we have implemented a clinical decision support system to remind physicians to do that. If you didn't do that, you had to make a note to explain the reasons of no prescription. According to our data, the heart failure GDMT practitioner rate can be significantly improved after the implementation of the clinical decision support systems, as you can see here. By doing this, the performance of the smoking abstinence can be well noted. We have won the silver medal in referral in the consecutive 2 years and the bronze medal in success on the smoking abstinence competitions by the Taiwan Society of Dependent Atherosclerosis. The assessment of the both ischemic and the bleeding risk in patients with acute coronary syndrome is very, very important in terms of selecting a strategy and treatment modalities. However, the assessment rate was not so good before the quality improvement in our hospital. Therefore, we implemented a clinical decision support system to optimize the risk evaluation, and the result was so good. The center score represents the severity of coronary artery disease and the Euroscore 2 surgical risk. The clinical guidelines highly recommended to a calculation of the center score and Euroscore 2 in patients with the severe coronary artery disease to facilitate a further discussion in the heart team meeting. We have conducted quality improvement activity to optimizing the center score and the Euroscore 2 calculation in our hospital.
The next step is to develop the activation mechanism of heart team discussion. By running this quality improvement activity, we got a better performance, and we have won the gold medal from our hospital quality improvement poster competition and the Cooperative Synergy Development Center continuous quality improvement poster competition as well. The heart team will be activated after diagnostic test or at 16:30 p.m. Every weekdays. For patients with the complex coronary artery disease, and the cardiovascular and the cardiovascular surgeons will meet together to review angio, discuss, and explain the results of the meeting to the patients and their family. The meeting minute will be recorded during the meeting. As you can see here, the center score, Euroscore 2, and the results of the meeting, and assigned by a cardiovascular and cardiovascular surgeon and the patient and family as well. After 6 months quality improvement process, the assessment rate of center score was from 4% to 96.5%. And the activation heart team discussion was significantly increased from 26.4% to 73.8%. The capture rate for patients with complex CAD tended to be higher after quality improvement. When we compare the clinical outcome between patients with heart team activation and those without, our data clearly demonstrated that the primary composite endpoint, including death, MI, stroke, and planned revascularization, tend to be lower in patients with heart team activation. This is a good news, and to support the implementation of heart team activation in patients with severe coronary artery disease. We have established some regular meetings for interdisciplinary crosstalk, such as the cardiac meeting, CVCVS Combined Conference, and a cross-team meeting, the cardiovascular quality meeting, and the healthcare meeting as well. We have established an interdisciplinary healthcare platform for crosstalk and chatting on the IT system. And we also have a TRM, interdisciplinary round program in the intensive care unit. And we have an implementation of iDashboard to improve the patient safety. The enrolled cases are indicated on the hospital information system, emergency information system, and the PCS to facilitate communication between interdisciplinary team members. We are also devoted to develop the artificial intelligence system to provide a clinical solution. For example, the regional motion abnormality in heart echoes is usually identified and differentiated by a doctor's eyes. However, there's usually an inter-observer variance. In order to solve this problem, we have developed the AI system to help a physician to recognize the regional wall motion abnormality. The results have been published in the top-ranking journal in the cardiovascular field circulation. The emergency doctors are struggling in identifying ST ablation myocardial infarction from challenge ECG. Although we have some quality improvement activity and strategies with ED doctors, however, this remains a residual problem. To assist the ED doctor to identify a STEMI earlier, we have developed the artificial intelligence system. Only 1 second, you can easily attempt the result. As you can see here, this is selected for STEMI ECG. The clinical guidelines highly recommended LDL goal for patients with coronary artery disease and acute myocardial infarction. However, there is a significant gap between the real-world status and the clinical evidence. Therefore, we have established a clinical decision support system to promote LDL goal attainment at the outpatient clinic. This system will capture CAD coding and screen the recent LDL cholesterol levels and lipid-lowering agents by the IT system, and the reminding window will be popped out if the LDL cholesterol is still higher than 70 mg per deciliter. As you can see here, the baseline goal attainment rate is low in patients with CAD or AMI. After the implementation of this system, you can really appreciate the significant improvement in the goal attainment rate, either in the CAD or acute myocardial infarction. We have won the bronze medal with this program from the 2021 Thai Society Lipid Association Optimizing Lipid Goal Attainment Competition. The case manager will follow up the enrolled patients after discharge, and the follow-up record will be easily accessed in the electronic medical record. The case manager will also notify the in-charge doctors about the residual problem during the follow-up, assisted by the IT systems. When their patients are coming back to emergency department or admitted to the hospital, the system will automatically notify the in-charge doctors and the case manager for further suggestion. The previous presentations showed the single center experience of ours, but how about the nationwide data? The chronic kidney disease is also one of the DSC in Taiwan. When we look at the nationwide data, you can really appreciate a significant improvement in the quality indicators, such as average serum albumin and average hemoglobin, and etc., as you can see here. With DSC impact on clinical outcomes, this is a very important issue. When we look at the evidence in the literature, for example, the acute stroke, you can really appreciate that DSC can provide a better survival rate after discharge and rehospitalization. How about myocardial infarction? We are very interested with these questions. However, there was no evidence in the literature previously. Therefore, we conducted a retrospective analysis by using the Taiwan Clinical Performance Indicator dataset from the Joint Commission Taiwan. And we are trying to match the hospital level, location, and service capacity between certified hospitals and uncertified hospitals, and to exclude the confounding effect of the emergency medicine service performance assessment. Finally, we got 9 certified hospitals and 11 uncertified hospitals. We found that the prescription of P2Y2 inhibitors during hospitalizations is very excellent, either in the certified or uncertified hospitals, as you can see here. So there was no significant difference between both groups. With respect to the prescription of statin before discharge, you can really appreciate that the prescription rates was significantly improved during and after certification period. And during certification period, the prescription rates was in favor of the certified hospital. The smoking abstinence consultation during hospitalizations, there was a significant improvement in the certified hospitals during and after certification. However, there was no significant change in the certified hospital. And again, the rehabilitation consultation during hospitalization, significant improvement in the certified hospital. However, no significant change in uncertified hospitals. And finally, the in-hospital mortality, a significant reduction in hospital mortality during and after certification in the certified hospitals group. However, no significant change in the uncertified groups. With respect to the cost effectiveness, we can only show the single center experience from our hospital. The average medical cost during admissions is going down in patients with AMI or complex CAD. So, ladies and gentlemen, to summarize today's presentation, I will conclude that the DSC enhanced positive intrinsic changes such as infrastructure change and cultural remodeling. And DSC can improve healthcare quality represented by indicators and may improve cardiovascular outcomes and reduce medical cost. Thank you very much for your attention, and I'm very happy to have your question. Thank you.
Okay, thank you, Professor Chao, for the excellent speech. From the study of Professor Chao, we can understand that the disease-specific certification process helps hospitals to reinforce infrastructure and to establish a team-based care model. The clinical outcome and care quality of acute myocardial infarction is much improved through the implementation of disease-specific care process. Now let's invite Professor Chao to give us a few words before we proceed to the next section.
Okay,
Professor
thank
Chao,
you,
please.
Professor Lee. I would sincerely thanks to the President of the ASQUA, Dr. Pachun Wang, and the President of the THQA, Dr. Chan, and the Chairman of the International Cooperative Committee of the THQA, Dr. Wang, for inviting me. The disease-specific care certification is now on fire in Taiwan. Although evidence regarding the prognostic effects of the DSC is still limited, we need more. However, I believe this program can provide prognostic impact on this specific disease care by improving healthcare quality, and I sincerely welcome hospitals and institutes in Taiwan to join this program. Thank you.
Thank you, Professor Chao. And now we proceed to the next session and welcome Professor Wu to host the panel discussion.
Thanks, Dr. Lee. In this discussion session, we have 3 panelists. The first one is Dr. Ting-Hsing Chao. He's the Director of Quality Management Center, Chimay Medical Center. And the second one is Miss Pauline Zhang. She is the Deputy Secretary, Taiwan Healthcare Quality Association. And the third one is Miss Chia-Ying Gao. She is the Supervisor, Taichung Veteran General Hospital. And thank Dr. Rahim and Dr. Dato for their talk
cover the hospital accreditation and the disease-specific certification. So now we invite Dr. Chen to have some comment or some question to these two speakers.
Okay, it's my great honor to have the chance to have some speech here. And I must thanks for our two distinguished speakers for these two excellent speech about the accreditation and the quality. And we know both DSC and the accreditation can trigger intrinsic pressure and facilitate intrinsic improvement and the cultural remodeling. And also patient had a better outcome and the hospital have a good achievement and the personal week have a paper publishment. And I want to ask both speakers, Chief Chao and Dr. Rahim, about what about you think about the possible impact of COVID-19 on your application or certificate on DSC and accreditation? And is there any encouragement like award or money about your path of DSC or accreditation? Thanks.
Okay, now we invite Ms. Ren. Ms. Ren, can you give us some comment or some question about these two topics?
Thanks for the introduction from the moderator. Have some. Okay. Thanks for the introduction from the moderator. Good evening, every guest. Thanks to the two speakers for their great presentations. Accreditation is the voluntary process by which a healthcare facility is accredited by the government or non-government agency against a set of specific benchmarks. One size doesn't fit all. Let's work together to find a better and a safer system. I have a question for Professor Zhao. I see a suspension bridge in the midst in your PPT. My question is, did you have any difficulty implementing DSC certification? How did you overcome it? Thank you.
Okay. Okay. Thank you, Pauline. Thank you for your nice questions. Yes, I believe that there are some challenges regarding the implementation of the DSC program in the institutes. I think the biggest challenge is to let our colleagues, especially attending physicians, to identify this program and engage this certification activity. I previously mentioned that there are some core elements of the DSC, such as the guideline, education, team, tailor management, communication, standardize, and the features. If colleagues cannot identify with the values and spirits of the DSC, it is impossible to make a good team with excellent communication to establish the clinical guidelines of our own and to let members to follow up these guidelines. The other thing is leadership. I think the full support from the administrative team of the hospital, including finance and logistics, is very important for running the DSC. For example, a good disease-specific care team needs case managers and the IT department to facilitate the setup of the infrastructure. It's a matter of finance and logistics. So the greater support, the better performance will be. It is a true thing for the DSC program. But how about to deal with that? For the biggest challenge, we have to try our effort to persuade and convince them in terms of the benefits of the DSC again and again. We should show them the evidence and also appropriately use the peer pressure. For the leadership, we should also persuade and convince the leaders of the hospital to support this program. Actually, this is no more a big issue among medical centers in Taiwan because the DSC program is closely linked to the hospital accreditation right now. Thank you for your question.
Okay,
Thank
now
you, Professor Zhao, for sharing your experience. Thank you.
Okay, now we invite our third panelist, Ms. Gao. Ms. Gao, do you have any comment or question to
I
these
have a
two?
question for Dr. Rahim. In your presentation, it's very good. You said what works for me do not necessary for you. So I would like to note in your countries how to enhance hospital direct to participation for accreditations. So
Thank you very much, Ms. Gao. Well, very difficult. Of course, it's a big challenge to change culture. Yeah? I think one of the trying to get them or engage them is the easy part. Getting them to change, that is the harder part, especially in terms of doing things in a different way. I've got a few examples. For example, in one hospital, heart center that we have, what you call the need for the management and the board of the hospital to actually understand that the whole work has to be reorganized to actually fit to the quality system that you're going to introduce into the organization. Right? That is very important because quality is just like research as well. If you want to have an organization to do research, then the work has to be reorganized in such a way and designed in such a way and reorganized that research is part of the work culture, or same thing with the quality culture. So once that is established, getting them to actually be comfortable with accreditation is much easier. A lot of the issues is basically it's about change management. Right.
okay, thank you.
Yeah.
I have a question for Dr. Zhao. In your presentation, have said implementation of a dashboard in ICU. What kind of mature data is the presentation on the dashboard?
Okay. The iDashboard was established in the surgical intensive care unit. Actually, we can get the condition of the disease and the severity of the disease on this screen, and we can also get the modified so-called Muse score on the screen to for early diagnosis of the patient's impending resuscitations. And we can also get the information of the stress of the staff, the care providers, such as the nurses, and then we can modify and to redistribute the workload between the nurses. So I think we can get more patient safety from the dashboard.
Okay, thank you.
Okay, thank you, three panelists, and your question and the discussion. I think in medical quality control and the patient safety, right now we are looking in hospital level and we begin to the disease level. Someday, if we have a big data and use artificial intelligence, maybe we can go into the personal level. So it's no end for the improving of medical care. So we still need to have this kind of meeting and share everyone's experience and knowledge to improve our medical care. Thank you all the panelists. Now I hand over to our chairman, Dr. Huang.
Thank you, Professor Wu, and thank you, Professor Rahim, Abdul, and Professor Zhao. Excellent talk and mention about the accreditation and quality care in the hospital. And also thanks for Dr. Lin, Dr. Lee, and Dr. Wu's moderator, and Dr. Chen, and Ms. Chen, and Ms. Ms. Gao for panelists. And we have a very, very wonderful evening for the International Quality Library Master Webinar Series. Please keep to follow up our website. We will have more webinar about quality care in the future. We thanks for the Taiwan Healthcare Quality Association and the Joint Commission of Taiwan and the Asian Society for Quality in Healthcare to hold this event. We hope to see you very soon in the future, in person or in the webinar. Thank you. Have a nice day. Thank you. Good night.
Good
Good
night.
night, everyone. Thank you.
See you. Bye.
Bye.
Bye bye.
Bye bye.
Good night.